I really hope you watched part 1 of HIV. This is part 2, day 2 of HIV week on the channel. If you didn't, then you're already one video behind. Grab your piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we'll look at medical topics in depth. Today we're going to be aiming to continue our videos on HIV. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such videos every time I post. Grab your piece of paper, grab your pen, and let's go. So in the previous video, we looked at the HIV basics. We also looked at the morphology, the clinical features, pathophysiology, pathology, and clinical staging. If you didn't check that video right now, you can just simply pause this video and just go to the playlist and go to the previous video. I will leave that tagged at the end such that if you do not understand this lecture, then you can actually refer back to that video so that this lecture starts to make much more sense. In this video today, we're going to look at diagnosis of HIV in adults, pretty much your pregnant women and your non-pregnant women. We're also going to be looking at the diagnosis of HIV in children, along with other investigations that we're going to be ordering. I won't go into depth about the investigations that we do when we are monitoring patients on treatment of these drugs, because I'll discuss that when we look at the treatment guidelines. So in the view of the new style of my questioning system, or rather the new style of my videos on the channel, I usually start off with a warm-up question. So pneumocystis jirovecii infection in an HIV-infected patient, A, commonly presents with copious, I think this is supposed to be sputum. B, more likely to occur with CD4 counts below 200 cells per microliter. C, sputum microscopy is the choice of specimen. D, widespread crackles are common. E, chest x-ray can exclude the disease. So you may pause the video, answer it right now. I'll give you the answer at the end of the lecture, and let's jump right in. So remember that when we make a diagnosis of HIV, we want to suspect HIV pretty much in patients that present either with persistent or even unexplained generalized lymphadenopathy, or generally any patient who has an AIDS defining illness. Then we want to actually do a test on them. And then we may also get history of high risk behaviors in their history, of course, and they may also even present with symptoms that may represent an acute primary infection. We talked about those symptoms in the prior video. Then, of course, this is the things that you really need to note about HIV testing for all the individuals. So the first and foremost thing is that all individuals must actually be entitled to an HIV test. No one should be denied an HIV test. That's the first and foremost thing. Then when someone actually goes for testing, there should be some counseling that is offered to this patient. So pre-testing counseling, pre-testing information that should be given to these patients, the benefits of getting an HIV test, the benefit of knowing your status, and of course the other important things like what would happen if you were found to be positive, what you should do, what would happen if you were found to be negative, and what you should continue doing. Then of course there is a post-testing counseling. Now in case of when an individual gets a negative test, what then? If an individual gets a positive test, then what do they do next? Then of course there should be linkage to appropriate HIV prevention services, treatment services, care services, and there's also other clinical and supportive services. Then of course we also use a screening tool. I will allude to it a bit later on in this lecture, and this is actually reducing the unnecessary HIV tests that we don't want to carry out. For example, if we already know that a patient is HIV positive, it doesn't make sense for you to order an HIV test again. We know that there is no cure currently for HIV, so there's no point in us ordering unnecessary HIV tests. If a patient is actually HIV let's say if a patient is actually HIV negative, but they are at low risk of getting HIV, then in some of these cases, we may not actually order for the test. Then, of course, the HIV testing services can be conducted by all healthcare workers, as well as those that are trained and certified and actually know how to do testing. There are some tests that can be done at the point of care. There are some tests that actually require some laboratory testing, and they're much more expensive. They take a much longer time, and the turnaround time is usually like a day. But usually the ones that we do at the point of care usually are very quick. Within 15 to 30 minutes, you're able to get your result. Then, of course, your HIV testing services must be done at all health service delivery points. Any clinic, any hospital must be able to offer HIV testing services. Now, in the community, especially, you may have what is known as hotspot testing and index testing. So hotspot testing is pretty much going to be targeted at particular populations or particular places that are going to be sharing similar characteristics. For example, we know that, let's say we have the map of Zambia and we realize that, okay, the transmission of HIV is highest in the northern province. That's going to be in the northern province specifically, maybe in Kasama to be specific. It's a random example. Kasama, for example. Then we would know that that's a hotspot because of the certain risks that people in this area are exposed to when they're getting an HIV infection. And then, of course, we also can realize that in this area, we get a lot of positive results. So these hot maps, actually, it's where we should actually tailor our community testing. And also there is something that's known as index testing, which actually uses partner notification. For example, if you get a positive result, you would want this person to give you the contacts of all the other people that they may have exposed to this virus. So it means all the partners, and if there are children that are involved, even the children should actually get tested. Then, of course, these hotspots are supposed to be mapped every 6 months because trends usually actually change. And then whenever you're doing any HIV testing, it's very important that you keep in mind these following things. So the first and foremost thing is that the information must always be provided in a confidential manner. So unless if this individual is a minor, okay, and hear me right, a minor, there's a legal age in different countries. I want you to comment what's the legal age in Zambia. Comment in the section below so that for those that don't know, you can actually tell them what the legal age is in Zambia. So if they are minors, then their legal guardian is the one that is entitled to know all the results concerning the child. Only their legal guardian. But if they are above the age of that of a minor and they can make legal decisions, then it is up to their discretion as to who you can tell or you can't tell. So it means that if you do test this patient, even if it's a couple, and you test the husband and the husband comes out positive, you can't tell the wife if the husband says, please don't tell my wife. That's actually a litigation issue. That's actually a case that can go to court if you do breach that, because this is a confidential matter. So the only place where you can actually tell the other individuals is if you have been consented by this person, that you can go ahead and tell them that about my status. That's the first and foremost thing. And then those that opt out of the test, it's not a forcing matter. Do not force anyone to get an HIV test. If they don't want to get an HIV test, let them be. Just continue counseling them, continue offering them the HIV test, and also provide them services to test themselves at home. Then, of course, we should also administer a screening tool to determine those that are eligible for the HIV testing. And if indeed they are eligible, then these people are going to be provided with counseling on the benefits of them getting an HIV test. They're also going to be provided with services that are going to be available for those that are HIV negative as well as those that are HIV positive individuals. Then we should provide the correct results following an HIV testing algorithm. I will show you this algorithm very soon during this lecture. Then, of course, you should elicit any contacts, whether sexual contacts, biological children, needle sharing partners. These should all be contacted and they should get an HIV test. Then, of course, they should provide linkage or connection to prevention as well as treatment and other care services for all patients that are found with HIV. Because now we are running what is known as the test and treat. Way back, we used to wait for your CD4 count, we used to wait for your viral load, but now you can actually even be initiated on treatment the same day when you get a positive result. Now, what are some of the screening tools in adults? So we want to determine the testing history. So if a patient is HIV positive, you should not, if they're already a known positive patient, you should not repeat the test. So these patients must therefore be linked to care. If they're not on treatment, they should be counseled on adherence. Every time you meet the patient, counsel them on adherence and compliancy, such that you should ensure that this patient is virologically suppressed. Then, of course, all key populations, especially the high-risk individuals, must get a test every single month. And for all the other individuals, you can get it every 12 months. 6 to 12 months is okay. Then you screen for symptoms that are suggestive of HIV. We talked of the different symptoms yesterday, the different manifestations on the different systems. Then, of course, screen for any high risk HIV exposure. So it could be things like a symptomatic screening for HIV-associated illnesses, sexually transmitted infections. It could even be screening for HIV exposed sexually or through different means like blood, fluid contact, or even all individuals with symptoms that are going to be suggestive of HIV, or they have recently participated in an activity that may have exposed them to getting HIV. Then for all pregnant women, for all breastfeeding women, they must get an HIV treatment or an HIV test rather every 3 months, regardless of the risk of exposure. All breastfeeding women, all pregnant women must get an HIV test every 3 months. But of course, the clinician can actually override this screening tool. If they feel like the patient actually needs an HIV test, they can suggest this and they can order for an HIV test. Then, of course, in children, all children that are HIV positive, they're already known positive cases, there's no need to test them again. Then, of course, the HIV negative children with a documented result with no known HIV risks, then you shouldn't test them again because there's no known risk. There's no way that this child could have contracted the HIV unless if there is a risk. So it could be risks like, for example, the biological mother is positive and they're breastfeeding perhaps, or it could be that the HIV status of both the parents are unknown or the parents are deceased, or it could be as a result of sexual assault, even exposure to HIV-infected body fluids. Then you should test these children. Then, of course, there is an age-appropriate test that is given to the children. I will talk about this a bit later on in this lecture about the different tests that we do for HIV patients. And then, of course, just like with the adults, the clinician may override the test where they deem or see that the test actually, the screening tool is not really yielding anything, and you can actually test the children and rule out HIV. Now, remember that the screening antibody tests or the newer combination of antibodies and antigens are going to be offered routinely to adolescents. They're going to be offered routinely to adults. They're going to be offered routinely to the pregnant women, even the children, regardless of any perceived risk. Now, for individuals that are at high risk, those that have multiple sexual partners, those that do not practice safe sex, these are going to be tested every 6 to 12 months. Then this testing should be done in confidentiality. It should be available. It should be free of charge. In the public institutions, it's free of charge. And actually, the WHO actually suggests that in countries in low income as well as medium income countries, the testing should be done with using combination of 2 different rapid tests. And I will show you what we do here in our setting, the tests that we use in our setting. And of course, the rapid tests have an advantage because these ones, you can get a result in less than 25 minutes. The patient doesn't need to go home and come back. They don't need to wait a day for a turnaround test that you get with some of the lab tests that I'll talk about. Then, of course, the patient can actually receive HIV testing, and they can be provided with information, they can be provided with care, and of course, treatment services wherever appropriate. Now, what are the HIV tests that we can actually do? 2 main types of tests. We have those antibody or antigen tests where they check for either an antibody or they check for an antigen. Remember that there was a very special antigen that I alluded to in the previous lecture, which was known as the P24 antigen. So we can either check for antibodies against this antigen. There are different tests in which we can do this, or we can check for the antigen itself, or we can check for either one of them. There are some tests which actually combine, which can actually give you a result whether the antigen is present or the antibody is present. Now, these ones are the ones that are actually much more accurate. Why is this so? Because there is a period that's known as the window period where you have the HIV infection, but you haven't yet formed antibodies against this HIV, which happens in the very very few weeks of infection. I talked about it in the previous lecture. So whenever you are in this window period, then you can check for the antigen, because as long as you have the HIV infection in the body, then you're pretty much going to be having the antigen being positive. Alternatively, you can order for some nucleic acid testing, where there is nucleic acid amplification assays that can be done to determine the HIV RNA level. These can also be used to determine the viral load. So let's go into details about the antibody antigen tests. So these ones are used to detect HIV. They're very sensitive and they're very specific, except in the very first few weeks. The different generations of the tests that were made, we're now currently at the 4th generation of the test. The earlier generations just checked for the antibodies. They didn't check for the antigens. What we realized that in the very first few weeks, when someone is actually in the window period of the acute HIV infection, when you check for these antibodies, they're not going to be present. And remember that if these antibodies are not going to be present, it doesn't necessarily mean that the patient is HIV negative. So you'll get a false negative result because you tested them too early. The antibodies haven't yet formed. However, now with the newer tests that we actually developed, these now checked even for the antigen, the P24 antigen that can be detected quite early in the blood. So we actually combined this into one test, and this is now, we're currently at the 4th generation antigen and antibody combination immunoassay. And this actually detects whether you have HIV-1, HIV-2, the antibodies against the P24 antigen, or even the P24 antigen itself. So you can actually know. They won't tell you whether you have HIV-1 or HIV-2. You have to do an additional test to actually differentiate whether you have HIV-1 or HIV-2. But they will tell you that you definitely have HIV. Then you can also order for some RNA assay determination. You can also order what is known as genetic testing. There are different types of genetic testings that we can actually do. There's what is known as the genotypic testing, where you can actually test the genotype of the virus, because we know that there are certain mutations that are very common on the HIV virus. So you can do this. We know this is genotypic resistance testing. You can also do what is known as phenotypic resistance testing, where you culture the HIV in cells. Then of course you expose it to the antiretroviral treatment and you see how it responds to the antiretroviral treatment. That's known as phenotypic resistance testing. Then of course the laboratory version of the antibody antigen tests actually is preferred over the point of care, but of course this takes if you don't have the laboratory to actually do this, then it's very difficult to do. So you would rather depend on the point of care, because these ones can be provided to almost every health facility in the country. So this is the point of care. It comes as a strip like this. This is at the point of care where you place the blood here. Then of course you read the strips over there. Then of course there's one where you actually use a machine and it's a lab based. This one is actually, takes a bit of some time, and because you have to send the sample to the lab, and sometimes the lab may be overwhelmed with other tests that they're running for other patients. So usually for patients where we know that this patient may not really come back, then we'd rather do this point of care test, which is much faster. So these are serological tests. Let's go now. The antibody antigens are serological tests. So there are going to be 3 important types. Generally in our setting, we usually depend on the rapid HIV tests. So we have what is known as an ELISA, which can actually be done in the lab. So this one is known as an enzyme-linked immunosorbent assay, or ELISA for short. Now this one just simply is the standard screening test for HIV. We send the samples to the lab. Now we can send a small sample of blood. We can send oral fluid. Take note, not saliva. What you simply do is you get a spatula-like instrument, and then you rub it across the gums and the cheeks, and you of course send that. It's actually as sensitive as blood. It can also be done on urine, but urine is not as accurate as blood. It's not as accurate as the oral fluid. This test is actually very, very specific, about 99.5% specific for HIV, but it's not so sensitive. So it means that you may get some false negatives, false positives if the lab makes a mistake, or if the patient has not yet developed antibodies, because remember, this is an antibody test. Then of course a positive test is going to be confirmed by another test which is known as a Western blot test. So the Western blot test is actually a confirmatory test. Now remember that the ELISA here it needs a lab to be done, and it needs skilled personnel. It takes several hours for you to do. The Western blot, on the other hand, is an excellent confirmatory test. The reason why we use this for confirming is because it's highly specific, but it's not so sensitive. So it means that you may test a lot of people and you may not be able to pick up that they have HIV. So it's not so sensitive. That's why we use the ELISA as a screening test as the preliminary. Then once we get a positive result with this, then we then go and do a Western blot. Both of these tests are pretty much checking for antibodies. Now, this is just different ways in which the tests are carried out. If you want to learn a whole lot about this, just visit a lab, then you see how it's actually done. Then, of course, it should not be used for screening because it's used to confirm a positive ELISA. And when you're combining the ELISA test and a Western blot, then this is going to be 99.9% accurate. These are lab tests. They require skilled personnel. They're quite expensive to actually carry out. The ones that we actually do are your rapid HIV antibody tests. These actually have a reasonable sensitivity and reasonable specificity, which is above 99%. They are very easy to carry out because you do not need a continuous supply of water, you do not need electricity, and it can be done by a less skilled person, and the interpretation of the result is actually quite easy. The results are available within a few minutes, with less than 30 minutes as compared to these other tests which actually take a while. Then, of course, we can do an antigen test. Now, these have now been combined together with the antibody and antigen test in one test kit, the 4th generation types. So these ones are just pretty much going to be checking against the P24 viral proteins. Now, these are going to be detected quite early in the infection. So that's why we can actually use this in the window period before the person actually seroconverts. Now, remember that the early generation enzyme-linked immunosorbent assays, the ELISA antibody tests, are actually quite highly sensitive, but they do not test for the antigen. So they're not going to be positive in the early phases of the disease. Then they are not positive in the early stages, but the 4th generation tests, the ones that actually combine the antigen and the antibody, these ones actually are really positive in the early stages. And remember that we're going to be using our ELISA as our screening test, then we confirm it with Western blot. Now, the drawback of the ELISA and the Western blot is that the ELISA requires some complex equipment. It requires a lab for you to carry out. As well as the Western blot, it requires the well-trained technicians, and it's quite expensive. And of course, the full sequence of testing would actually take at least a day. So that's why we generally don't do this in our setting, as in the government hospitals. Then, of course, you have the nucleic acid tests. Now, these ones pretty much are going to be checking for the nucleic acid. These ones are very, very sensitive. Now, if you get a patient and you do an antibody test and you find out that it's negative, but you still think that this patient has HIV, especially during the first few weeks of the infection, then you can do a plasma HIV RNA test. Now, these nucleic acid tests are amplification tests. They're very sensitive, very specific. So they can actually detect as little as 1 to 10 copies of the proviral DNA per mil of blood. And that's a very sensitive thing. But the drawback of this is that they're quite sophisticated. They require highly skilled personnel to carry out. And the test costs a lot of money. So regardless of them being very specific and very sensitive, they cost a lot of money. But these are very important, especially in children. Now, why is this so? Remember, when a mother gets an HIV infection and she is pregnant, remember that the mother is going to be making antibodies. One of these antibodies is, of course, your IgG against your P24 antigen. Now, what's going to happen is that remember that IgG is going to cross the placenta. So it can cross the placenta and it can be present in the fetus. And remember that most of the antibodies that are in the mother are actually going to cross over to the fetus, the IgG antibodies, to protect the fetus. So the fetus is born with a high concentration of maternal antibodies. So if you test this child that is born to an HIV positive mother, and you realize that the child actually gets a positive antibody test, it doesn't necessarily mean that they have HIV, because what you're testing for are the antibodies. You're not testing for the antigens, you're testing for the antibodies. That's where now the nucleic acid test actually comes into a very, very good perspective, because we can actually use this in the children that are below 18 months to actually check for the nucleic acid of HIV that's present within the bloodstream of this infant. That's how these are very important. So the HIV RNA assays actually require advanced technology. They use what is known as reverse transcriptase polymerase chain reaction, and these are very sensitive. They can actually pick up extremely low levels of RNA in the blood. So measuring of the P24 antigens by ELISA is less sensitive and less specific than compared to actually checking for the actual RNA in the blood of the virus. Then, of course, so we use this to make a diagnosis in HIV exposed infants. So if a child is born to a mother that's HIV positive, we don't say that they're HIV positive until we confirm. What we say is that they are HIV exposed. And then after we test them, and if they're negative, then of course they'll be negative. If they're positive, then they will be positive. But as long as they are at risk, we tend to put them on prophylaxis, of which I will talk about. Additionally, this nucleic acid test can actually be used to diagnose and confirm virological failure in patients who are actually not responding to the treatment. They can also be used when there is an indeterminate result from your antibody test, when you're not so able to pick out the result. Now, so a patient comes in. So this is how the testing schematic is going to be happening in our setting. So a patient comes in. Remember that most of the tests that we're going to be doing are rapid test that we're going to be doing, unless if we send it to the lab, and in the lab they do much more extensive testing, but this is what's going to be done in most of the hospitals. So the patient comes in, and when you test the patient with a screening test, which is obviously going to be an antibody antigen test. So if the patient is negative, there's no need to actually repeat the test. Then you just report this patient as being HIV negative. They do not have HIV. Now, if you do the first screening test and the screening test turns out to be positive, then you do a second test, which is a confirmatory test. Now, this confirmatory test, there are two possibilities that you can get. When you do the confirmatory test and you realize that it is positive, then you have to then type their HIV, whether it's HIV type 1 or type 2. And then this is, of course, your genetic studies. Then, of course, if it's negative, then you have now created a very, very important scenario, because you did the first test, it was positive. Then you do the second test, then the second test is negative. So you have two tests which are giving you two different results. So generally you want to repeat the test using the same specimen. You can either do test 1 or test 2. So you want to do a tiebreaker for this. So if both test 1 and test 2 are reactive, then you say that the patient is positive. If both test 1 and test 2 are non-reactive, then you say that the patient is negative. But then again, if you get opposite result, discordant results, where one is negative and one is positive, you tell the patient to come back after 14 days, then you repeat using the same test. So the screening test we use is a determine test, the confirmation test is the Unigode, and the tiebreaker we can use the BioLine. So this is the determine test, which actually combines your HIV type 1 and type 2 antigen and antibodies. This is what it actually looks like. So this is actually the first FDA approved rapid point of care test that detects HIV 1 and 2, and then it also detects any free HIV 1 P24 antigen. Now remember that this is a 4th generation type of test, and it can actually identify HIV quite early, even in the window period, as opposed to the 2nd and the 3rd generation test, which only use antibodies. So it can actually enable healthcare providers to actually diagnose HIV in the very, very early stages. Now this is what the test actually looks like. So on the top there, you have the lot number. Here you have your patient identification. Here you have the name of the test. Then, of course, you have the control line. The control line should be present. If you do not have the control line, it means that this may actually be a faulty test. It may not actually be reliable. The first line here after the control line is the P24 result. So this, if you have this line there positive, this line positive, and this is for the antibodies. If all three of them are positive, then definitely this person does have HIV. Then, of course, this is the sample pad where you actually place the sample over there. So if you get a positive result from this, then you have to then order for a second test. Now, the second test that we can actually order for is the Unigold test, which is also another rapid diagnostic test. This one also is a qualitative test that detects for antibodies. Now, this one is not going to be detecting for the antigens. This one is going to be detecting pretty much for antibodies, where you have your HIV against HIV type 1, type 2. You can use serum, you can use plasma, we can use whole blood. So it can also be used at the point of sale, a point of care, not point of sale. And actually, the WHO actually recommends that you use at least 3 reactive tests to confirm that a patient has HIV. That's why I had those 3 tests on the previous 2 slides. Then you have our BioLine, which pretty much is an immunochromatographic assay. This one here can now enable you to actually detect antibodies against type 1 and type 2. Type 1 including the subtype O, the HIV 1 subtype O, and the HIV. You can actually determine which one this individual actually has. So usually the BioLine is what we use to actually as the definitive thing. Once you get the BioLine and it's positive, you definitely have HIV. So the newer tests actually that use blood or saliva, you may have things like particle agglutination, immunoconcentration, immunochromatography. These are actually very, very quick. They can be done in 15 minutes. They're very simple to use, very simple to read. They're just like a pregnancy test. If you have ever used pregnancy test, it's very easy to actually read an HIV test. Now, these ones should be confirmed. They should be confirmed by the standard blood test. So your ELISA, with or without a Western blot. In developed countries, then of course a repetition of more than one in the developing countries. Like I said, in our setting, we repeat more of these rapid tests because people can't really afford ELISA or Western blot. It's expensive, and even just where to do the test in the first place is not offered in every single hospital in the country. Then of course the negative tests from any of these should not be confirmed. Then other blood tests that we can order for a CD4 count. Then this is actually an indication of the level of the immunosuppression the patient has. And generally, it ranges between 1,000 to 1,200. So yesterday I gave you a value of 750. So you can say plus or minus 250. So that gives you about 1,000 or so. So in patients with HIV, the CD4 counts actually begins to drop about 50 to 100 cells per year. So the CD4 count must not be used to make a diagnosis of HIV. We should use the antibody test, the antigen test, as well as the nucleic acid test. Then of course the CD4 count is no longer used actually to determine whether we should start patients on treatment. So if they are found positive, we start them on treatment there and then. Then of course the CD4 count can be used to follow up the progress of the antiretroviral therapy that the patient is on. But viral load is actually a better way in which we can actually see if this patient is responding to the treatment, and it's a much better proxy. And we should do the CD4 count testing every 3 to 6 monthly. I'll talk about this when we look at the testing, the monitoring of treatment. Then of course the CD4 count may vary depending on certain circumstances. It has a diurnal variation, so it's high in the evening, it's low at midnight. And then of course intercurrent infections, use of steroids, stress can also affect the CD4 count. Additionally, you may also do a viral load, so the plasma levels of the RNA, and then of course this is going to be reflecting the HIV replication ability. So the higher the set point, the higher the viral load, it means the quicker the CD4 count is actually going to drop, and the greater the opportunistic infections that are going to be setting into this patient, even if they do not have symptoms. Then of course your baseline genotypic testing I already talked about, where we look for various mutations which we actually know that can cause resistance to certain antiretroviral therapy. It's known as genotypic resistance testing. There is also something that's referred to as phenotypic resistance testing. I already alluded to that much earlier on. Additional tests that we may do a hepatitis panel, especially for hepatitis B and C. We may do a full blood count and an ESR. We may do your liver enzymes, that's your AST and ALT. We may order your serum creatinine. We may order for our RPR against syphilis. Of course, with syphilis, there are also much more specific tests, your treponema hemagglutination tests. We should also order for an AFP, an acid fast bacillus test on the sputum. We can also order gene expert on the sputum if we're suspecting TB, a chest x-ray wherever possible, stool for ovine parasites, malaria parasite slide, a pregnancy test must be done in all women of childbearing age. We should screen patients for TB, screen them for PCP. So on the chest x-ray, you may see this bilateral interstitial infiltrates, and generally with the pneumocystis jirovecii type of pneumonia, they tend to desaturate very quickly, especially when they take them off O2. Screen for hepatitis A and C, A, B, and C. Screen for syphilis, screen for toxoplasma. You may get these ring-enhancing lesions on the CT scan or the MRI. Screen for cytomegalovirus, cryptococcal infection. So you can do cryptococcal antigen testing on the CSF. You may do this on the serum. Of course, genotypic testing to guide the treatment. You may also do a pregnancy test in women. Like I said, any woman that's of reproductive age, you should consider them pregnant unless proven otherwise. Then, of course, some baseline tests like a full blood count, UNEs, LFTs, lipid, as well as glucose. We will do these tests also at specific intervals when we're monitoring treatment. Now, there is something that's known as a repeat test and retesting. So any case that's going to be yielding an inconclusive result or discordant result, you should repeat the test. So you should use your determine and your BioLine algorithm, the one that I showed you much earlier on. You repeat the test. So this usually uses the same specimen. Then, of course, in certain situations where there is possible HIV exposure within the past 3 months, or there's ongoing exposure, like for example, an HIV positive partner, sharing of injected equipment, or even after PrEP or PEP, then we pretty much want to redo the test. We want to retest this patient and get a new sample and retest this sample. Then, of course, there is something about HIV self-testing. So I don't know. Let me know in the comment section below. If you were to test yourself and suppose you found out that you were HIV positive, how would you take it? Would you seek help? Would you not? And do you think that it's a good idea that you should allow people to test themselves? Let me know in the comment below. So the HIV self-testing is where an individual collects their own oral fluid or their blood, then they perform the test on themselves. Then, of course, they do a rapid test and they can interpret this. They can either interpret this privately or they can actually help elicit the help of someone that they trust. A lot of people to send me a lot of test results and ask me to interpret what's up with this. Is this positive? Is this not? And then, of course, that can also be done if you trust the patient, if you trust the person, rather, it can actually be done. So this is targeted particularly at individuals or populations with a high risk of HIV acquisition. So those that are less likely to access testing services or test less frequently. So men, adolescents, key populations, even serodiscordant couples. And the testing can actually be assisted or unassisted. It's assisted if you have the presence of a trained provider or someone who has some knowledge in reading these things, where they can actually demonstrate before or during the test on how to performing it, how to interpret results. It's a very easy thing to do. You just look at the lines. It's like a pregnancy test, like I told you. Then, of course, the unassisted type, where now the individual actually tests themselves for HIV and they use the HIV self-testing kit and they follow the instructions. I remember when I tested myself with the oral test kits, because they brought these oral test kits back when I was in med school, and they brought these oral test kits, and then we were so excited about them, and we got a few of them. I came home. I did not tell anyone about it because, just in case it's positive. I did not tell anyone about it. I went in my room. I pretty much read the instructions of what you do. Okay, fine, do this, do that, and then I did that, waited for the time until I read the results, and eventually it was negative. That's how I went to tell everyone that, by the way, I tested for this. So that's why I'm asking, would you think it's actually a good idea that people should be testing themselves? Please comment in the section below. So an HIV self-testing actually is a screening test, and it requires further testing. So even if you test yourself at home, we should actually test you further if you found yourself to be positive at home, and we should confirm any positive results. The negative results, there's no need to actually reconfirm them. Then we should actually provide services and information of how to test yourself, how to interpret the results correctly, where to access these HIV testing services and other further services, how to dispose of these testing kits quite safely, and of course the ethical and the legal obligations. Like, for example, you can't go around testing everyone at home. I can't just get test kits and start saying, hey, open your mouth and start rubbing everyone's mouth and testing them for HIV. That's unethical to do. And of course, the self-testing is not used as a prerequisite to a determined test. So it should not be used as a screening test either in the community or at a facility. So all results must be confirmed. So the use of this testing in a known HIV patient that's positive, there's no need for you to test yourself again. You already are HIV positive. The result will not change. So this is how it goes. So we have HIV testing, which is assisted or unassisted. So if it is a reactive test, then you have to confirm this result at the clinic by a trained professional using the validated algorithm that I showed you earlier on. And of course, if it's confirmed positive, you refer this patient for treatment. Then if the result is negative, then if there was a possible exposure in the past 6 weeks, or if there is an ongoing risk of HIV infection, you repeat the test after 3 months. Then, of course, you recommend comprehensive prevention services. Then you recommend comprehensive prevention services. If the test is positive after 3 months, you refer them to treatment. Then, of course, there is partner testing or index testing, where you focus this HIV testing on the contacts, the sexual networks, the needle-sharing partners, the biological children, those that are less than the age of 15. So anyone who's exposed to HIV, you offer them this test. So an index is identified as an individual that is newly diagnosed HIV positive client who has been identified with a high viral load. So that's what we call as an index. So contacts are elicited from the index, the source. You can think of the index as the source, the patient who is actually spreading the infection. So you actually can, contacts of this index could be sexual partners, biological children from female clients, needles, or even blade sharing individuals. Now, the process of index, with the index client sharing information on their partners, if the client is female or biological children under the age of 15, they can actually share this. Then, of course, the contacts should be followed up, and they should be informed of their risk of getting HIV, and they should be offered a result, an HIV test. Then, of course, those that test positive must be treated, and of course, they become the new index client, and then they should give them now the information of those that they have exposed to. So it's like you're tracing the network. Then, of course, if it's a female or biological child under 15, a needle or blade sharing partner, you elicit these, and then of course you start the process all over again. And of course, all testing services in this setting are done with serological tests, so they're done with antibody tests. And of course, an HIV negative client is offered a retest after 3 months to actually remove the doubt of the window period, because if you're doing an antibody test, you're not checking for the antigen, so you want to retest this patient after 3 months. And of course, beyond the window period, they should be offered the testing according to the national guidelines. Now, there is partner notification, where it's a voluntary process where a trained healthcare professional actually asks the index client, or the people diagnosed with HIV in this case, about their sexual and even their drug injecting partners, and with their consent, obviously, to offer the test to these partners. And of course, this should be the patients that they were exposed to, preferably within the past 12 months. So they should remember everyone that they exposed to in the past 12 months, in the past 1 year. So this can be done either passively, or it can be done with assisted approaches. It's actually recommended to use the best approach for each index client. So each patient is individualized. And this is what I've always been stressing. When you're treating patients, make sure that you individualize the care. So you have the passive HIV partner notification service, and you have the assisted HIV partner notification service. So the passive one is where you get these now, the HIV positive patients, you encourage them, you as the healthcare worker, you encourage them to disclose their status to their sexual partners. You encourage them to expose their status to their injected drug using partners. And then, of course, you tell them to get the testing services. You advise them to advise those people to get this testing services because they could potentially be exposed to the HIV infection. Now, only do this if you're sure that this patient is going to tell the contacts, because sometimes people can just agree. You leave it up, you trust the contact, or you trust the index patient that they are going to tell the contacts, and then they'll just agree. And then this approach is actually less effective. Then, of course, with assisted HIV partner notification, this is where now the HIV positive patient actually consents. And then, of course, with the assistance of the healthcare provider, then they disclose the status to the other patient. It may be actually done where you actually know who it is, or it may be anonymous. So it may be anonymous where they just say, no, you have been exposed to HIV, and we can't tell you who exposed you to HIV, but you have been exposed to HIV and you need a test. Then, of course, the assisted partner notification is done by the service provider, and this is actually a much more effective way of doing things. Now, the provider contract, or rather contact, is where the HIV positive client, or rather contract, not contact, contract is where the HIV positive client now enters into a contract with the trained provider and agrees to disclose their status and the potential HIV exposure to their partners. Then, of course, by themselves, and then they refer their partners to the testing services with a specific time period. So if the partners to the HIV positive individuals do not have access to these testing services, or they contact the health provider within 14 days, then the trained provider will contact the partner directly and offer them voluntary services. Then, of course, the provider is going to, or the provider referral is where you have a healthcare provider confidentially contacting the person's partner directly and offers the partner voluntary testing. So here you just contact someone, you get someone's number, you call them and say, this is an anonymous person came to us and was tested for HIV, and you were afraid that you may be exposed to HIV. Of course, this brings a lot of issues and a lot of fights, because generally if it's just this one person that you have been exposed to, then you know that, oh yeah, this is the person that gave me probably the viral infection. Then, of course, you have dual referral, where the healthcare provider actually accompanies and provides support to the HIV positive client when they disclose their status and the potential exposure to HIV infection to their partners. Of course, this needs a trained person, because fights do break out in these times. Then, of course, in partner and family-based index testing, it's actually quite critical and important to ensure that the sexual partners and children under the age of 15 are also offered an opportunity to test for HIV. Then, of course, assessment of intimate partner violence should be done during this same index testing. Prevention of mother-to-child transmission should be done. Then, of course, gender-based violence, because these things actually do happen. Fights actually do break out with this, because it's a very sensitive topic. Then, of course, how to assess for an intimate partner violence. So the first duty, you as a healthcare professional, is to do no harm. So you should at all costs protect the safety of the index client. The partner who poses a risk of intimate, if they are providing intimate partner violence, they may need to be actually excluded from the partner notification service, because you don't want to endanger someone. So each named partner should be screened for this intimate partner violence using 3 questions. Has the partner ever hit, kicked, slapped, or otherwise physically hurt you? Has the partner ever threatened to hurt you, or has the partner ever forced you to do something sexually that made you feel uncomfortable? If the answer to any of these questions is yes, exclude the partner from the partner notification, because this will cause a lot of these gender-based violence issues. So here's the index and partner notification. So your step 1 is to introduce the index testing service to the index client during the pre-testing session, or the PMTCT or ART visit. Then, of course, obtain the list of the partners and also the biological children below the age of 15 with an unknown status. Then step 3, we should conduct the intimate partner violence risk assessment for each partner. Then, of course, we should determine the preferred method of partner notification or child testing for each named partner or the child. Remember the different types that I talked about earlier on. Then, of course, contact all the named partners and biological children less than 15 years with an unknown status. Then, of course, record the outcomes of the partner notification and family testing. Then, of course, we should provide services for children and partners based on HIV, on the HIV status. Now, here's the partner notification algorithm. Now, we introduce the partner notification services to the index client and obtain concurrence. Then step 2, we obtain a list of the partners who may be at risk for HIV infection. Then for each of the listed partners, we record the information, we screen them for intimate partner violence, and we determine the preferred method of testing. This is for the engaging the index client. Then when notifying the partner, we of course contact each of the named partners, and we use different approaches. So we can use the client self-referral, like I talked about earlier on. We can use the provider contact referral. We can contract referral, rather. We can use the provider referral. We can use the dual referral system. Those are the different systems that we can use to actually contact the partner. Then, of course, we record the outcome of the partner on the partner notification worksheet. There, you can just Google these things. There, partner notification worksheet Zambia. You would find it. Then, of course, we record all the data in the partner notification register. Now, when it comes to early diagnosis in infants, like I said, that in children that are less than 24 years, those that are breastfeeding, they should be tested. The mother should be tested first. Then, of course, if the mother is positive, then you should perform a nucleic acid test, which can be done on the HIV positive infant. Now, we do this regardless of the age. Now, the nucleic acid test can be performed on either a dried blood spot, which is known as a DBS, which is usually just sent to the laboratory, or you can get a fresh sample. That's if you have a point of care machine. You have the machine at your facility, then you can actually do the test there and then. Then, of course, the advantage of this is that you can actually get the results on the same day. If it's a point of care technology, you can get the results on the same day. Now, in infants who have HIV detectable by NAT at birth are more likely to have gotten it through in utero. So they may have gotten it during the pregnancy. These infants will actually progress to disease very rapidly, and in the absence of treatment will experience actually high rates of mortality during the first few months of their life. Now, infants infected at or around delivery may not have the virus detectable by nucleic acid testing for several days and even sometimes several weeks. So the ability of this NAT to detect the virus in the blood may be affected by the antiretroviral drugs that are being taken by the mother, the antiretroviral, the prophylaxis that is being offered to the infant, and even this may actually cause false negative results on the infant. That's why we usually have a way in which we test these children. So the drugs are also the antiretroviral drugs are also present in breast milk. So if the child is actually breastfeeding, this may actually interfere with the result. So the rationale behind the recommendation is that the infants who are first identified as HIV exposed postpartum have a higher cumulative risk of already having gotten the infection by the time the prophylaxis is actually initiated. So NAT should be performed around the time of initiating prophylaxis, which would be at birth. So we should do the first nucleic acid testing at birth, or at least at the first contact of this child. Then, of course, this will help minimize the risk of development of resistance because of extended prophylaxis in infected infants, and it will actually help promote linkage of timely initiation of ART, because no child in 2022 should be HIV positive and not be on treatment. No child at all. Then, all the testing sites should participate in HIV proficiency testing at least twice per year, and for all people conducting the HIV testing, they should include lay providers. Every 10th sample should be sent for external quality assurance testing at the nearest laboratory to at least make sure that the tests that are being put out by this laboratory are actually correct. Then, of course, all providers conducting the HIV test should be certified to ensure competence and quality in service rendering. HIV-1, HIV-2, or HIV-1 and HIV-2 positive results tested by community-based volunteers should be repeated by a professional in the lab. Then, of course, all HIV positive tested by community-based volunteers at community or facility level should be repeated by a professional lab personnel or a healthcare worker at the nearest health facility before you actually start them on treatment, because this is a lifelong thing. Suppose you've been taking now antiretroviral therapy for 2 years and you realize that you actually didn't even have HIV. And imagine all the side effects. So let's now look at the testing in the different age groups. So we'll begin with the pregnant women. So pregnant women, breastfeeding women, and their sexual partners, all of them should be tested. So when do we test them? Usually we're going to be testing them during antenatal. So at the first visit, we test them, then we retest them every 3 months if they are negative. In labor and delivery, we test them if their last test was greater than 6 weeks ago. If they tested greater than 6 weeks ago, we test them again. Then, of course, during postnatal care, we test them at the first contact. If we don't know the status, then, of course, we do a serological test at 6 weeks if it is negative. If they're breastfeeding, we retest them every 3 months if it's negative until the cessation of breastfeeding. Then, of course, the partner testing should be done at the same times that this woman actually goes for antenatal and the same times that this woman is actually in delivery. And the tests that we do are serological tests, so antibody antigen tests. Now, here is a very high yield table because it's in children. And I want to take my time here. I'll even zoom right into this table here. I hope this lecture is actually not so long. But anyways, so on the yellow aspect here, this is for children between 0 to less than 10 years, and then you have adolescents that are 10 to 19 years, and as well as adults. So you have those that are well, never breastfed, HIV exposed infants. So you test them at birth or at the first contact, at 6 weeks, then as well as at 24 months. So at contact and at 6 weeks, you test them with your nucleic acid test. That means that they've never breastfed. So they're HIV exposed, but they've never breastfed. So you only test them 3 times. And of course, you do a serological test at 2 years. If they're negative, then for sure that they are negative. Of course, if this comes out to be positive, then you want to confirm with your serological test. Then the infants that are well but breastfeeding and they're HIV exposed, this is how we test them. We test them at birth, we test them at 6 weeks, we test them at 9 months with your nucleic acid test, which can also be either at a point of care or it can be a dried blood spot. Then, of course, at 9 months, we test them with NAT. Now, the guidelines now changed, and these are the latest guidelines. So at 12 months, at 1 year, we start off with a serological test. If it is positive, then we do the nucleic acid test. Then if it's negative, we continue at 18 months, we do the same thing. If it's negative, we do it at 24 months. So these are the tests that are going to be done for a child that is well and they're breastfed. At birth, 6 weeks, 6 months, 9 months, 12 months, 18 months, and 24 months. If they've never breastfed, at birth, 6 weeks and 24 months old. So with an infant who has completely stopped breastfeeding, then it should be 6 weeks after cessation of breastfeeding. In children that are less than 24 months, then we do a serological test. If it's positive, we follow up with NAT. Otherwise, it would be when they're older than 24 months where we do a serological test. If they're asymptomatic infant with unknown HIV status at first contact, remember that we want to test the mother first. Then, of course, we can actually test the child using the nucleic acid test. And then we can actually follow up at 24 months with your serological test. Then, of course, if it's an infant or child who's symptomatic for HIV, immediately, regardless of the age, test them immediately. So we do your serological test and then we follow up with NAT for a positive serological test if they are less than 24 months. Then, of course, if there's a positive serological test in less than 24 months, at first contact, we repeat the NAT. Then, of course, all infants and children with an unknown HIV status admitted for inpatient care, attending malnutrition clinic or outpatient care or immunization, we administer our pediatric screening tool that I talked about earlier on. Then we test them appropriately according to their age. Then, of course, with the adolescents, or those that are sexually active with their partners, and any patient or any person with an unknown HIV status, then we should actually get a serological test for this patient. And then if it's negative, repeat the test every 3 months, depending on the risk that is present. I hope this has now shed some light on the testing that we do in children, and I hope you now all understand. Now, here's the serological testing algorithm. I think let me just zoom this as well. So here we have our universal routine testing, screening by healthcare provider. Then, of course, first of all, self-testing. If it's positive, then we test by the healthcare providers, the first screening test. And of course, if the first screening test is negative, then this person is reported as negative. If it's positive, then we do a second screening test. If the second screening test is positive, then report this person as positive. Then we have to confirm whether they have HIV-1 or HIV-2. Then, of course, if the second test is negative and it's discordant, meaning the first one was positive, the second one is negative, then we repeat using the same specimen, test 1 and test 2. And of course, if both of them are positive, we record it as positive. If both of them are negative, we record it as negative. If one is positive, another one is negative, we record it, or we tell them to go back, and then they come back after 14 days and we repeat the test. So this is the algorithm, the testing algorithm that is there for HIV. I talked about it much earlier on. I really hope you understand this. So the rapid test can actually be done for recent infections, and the background for this is that we want to actually have epidemic control, and the national HIV program has been implemented, and interventions that have been put to reduce the new infections from coming up. And of course, the information with which we get from all this and all this surveillance data is actually used to actually estimate the national and subnational HIV incidence. So we should test for all new infections, all recent infections. So what exactly is this recent testing, where we do an HIV test to diagnose HIV and distinguish recent from a long-term infection. So this test can actually be performed using a laboratory test, which actually takes several days to get a result, or the newer rapid test, which is known as a rapid test recency infection. Or recent infection. Then, of course, these tests only work for HIV type 1, so they're not going to be working for HIV type 2. So this same recent tests results can be available within 20 minutes. Then, of course, they evaluate and can actually distinguish whether this person has had a recent infection or it's a long-term infection. Why is this important? Because the recent infection is something that was actually acquired within 12 months. We want to see if the numbers are actually increasing in the country or they're actually not, as we already realize that there has been a sharp increase in the country of HIV. Now we want to tell whether if this increase was happening as a result of possibly people acquiring new infections, or these infections were long-term. So the purpose of this recency testing, or the recent testing, is of course we want to so newly acquired infections of HIV frequently are characterized by or have characteristically resulted in infected individuals having high viral loads, immature and even weak immune responses. And then, of course, individuals commonly having continued high-risk behavior and ongoing transmission, they get new strains. Then, of course, this strategy actually helps us identify new clusters of transmission. We also inform as well as maximize the efficiency of testing contacts, as well as the networking in the community, and also providing information to better help our patients, to better provide better care and better same-day treatment and same-day testing and same-day treatment initiation for these patients, to actually curb the transmission and to curb the high increase in HIV. Now, how will recency testing actually be done? So this would be performed on patients who have an HIV test which is positive, using the routine HIV testing algorithm that I alluded to earlier on. So to avoid false recent results, a recent infection testing algorithm with the viral load testing is actually used. So this algorithm actually combines the laboratory testing with clinical information to actually correlate, or rather correctly classify, the HIV infection as either recent or long-term. So the patients who are on ART or elite controllers, those infected with HIV type 2 or certain subtypes like the cluster D or the group D, they may actually show a positive false result for the recent testing. So you need to note about this. So to correct these, clear clinical and laboratory history can actually assist in avoiding these results or these errors in these results. Then, of course, persons who actually test recently with this type of tests, then those who test positive for this and have a viral load greater than 1,000 copies, then they're usually considered as a confirmed case, as a recent case. It means that they acquired this infection in the past 12 months. Then, of course, in Zambia, this HIV recency testing has been introduced using our antibody test, which is known as Ascente. And, of course, on surveillance basis while we await for the rapid tests for clinical use. So this is what it looks like. So this is actually a negative test. Of course, this is reactive. And then this is, of course, the long term. Okay, so this is the HIV testing. So we do the determine. If it's non-reactive, then of course it's negative. If it's reactive, then we do the bioline. And then of course the bioline, if it's non-reactive, then it's indeterminate, and we have to do the testing again according to the algorithm. Then if it's positive, then of course we test for recent infection. So if we do test for recent infection, and of course it's a recent infection, then we do a viral load testing. If the viral load is greater than 1,000 copies, then we report this as recent. Then of course this should be added to the national surveillance system and to the new cases that are being diagnosed of HIV. And of course if it's tested and it's a long-term infection, there's no need to actually inform the national surveillance system. But of course this patient should be placed on treatment if they're not on treatment. Coming back to our warm-up question, pneumocystis infection in HIV-infected patients, A, commonly presents with copious sputum, B, more likely to occur in CD4 count below 200, C, sputum microscopy is the choice of specimen, D, widespread crackles are common, E, chest x-ray can exclude the disease. So here the answer is most likely B. This is actually much more common in individuals that are having a CD4 count less than 200 cells. I really hope you enjoyed this lecture, even though it may have been very, very long, but I hope now you enjoy the different types of tests that we do for HIV, and I hope this has shed more light, especially if you're a final year and you're about to get into the system. If you did enjoy, consider subscribing, consider dropping a like, consider hitting the bell notification icon to be receiving notifications of such videos every time I post. My name is Dr. Moses Kazevu, to Zambia and beyond. Until next time, bye-bye.